So we'll pick back up in the second part of the APOCAN clinical training. We're back with the patient named Dana, a young patient. Simply shows that her APOCAN working within less than 5 minutes in her case, and giving her a total on, virtually eradicating for this filming all of her underlying Parkinson's symptoms that were so devastating when she was in the off condition. The next slide summarizes then from our phase 2 and 3 clinical trials that led to the APOCAN registration in the U.S., all of the key findings. APOCAN, when given as needed for the treatment of off episodes, provides a levodopa-like full-on effect within 20 minutes. In Dana's case, it was in less than 5 minutes. We know from clinical trials compared to placebo that 95% of a fluctuating patient's off episodes can be successfully aborted. We also know from long-term studies that once an optimal dose of levodopa of APOCAN is determined for any given patient, that there is usually not a need to creep up the dose over time. We know that from a study that was performed in patients taking APOCAN for more than 1 year on average. The dose, the effective dose range varies from 0.2 milliliters, that's the test dose where we start APOCAN, up to 0.6 milliliters is the maximal recommended dose. The maximal recommended dose frequency is up to 5 times per day as needed to successfully control off episodes. In the clinical trials, on average, patients were taking between 2 to 3 doses per day. We also know that APOCAN can be very effective for a particular kind of off episode that we call morning akinesia. These are patients who wake up in the morning and have a long delay in the onset to the benefits of their first dose of levodopa, or some doses of levodopa may not work at all. And in this phase 4 study, we demonstrated that APOCAN, in compared to levodopa, works much more quickly, usually within approximately 20 minutes, and more importantly, it works much more reliably, as demonstrated in this slide, in which nearly 1/2 of the motor diaries that the patients were taking, were recording each morning, had a dose failure with their routine levodopa dose, and that's as compared to APOCAN, in which only a less than 10% of diary days did they note a failure to turn on within 60 minutes. Let's move now from the efficacy of APOCAN from our clinical trials to safety. This slide summarizes all of the apomorphine versus placebo side effects that occurred in 2 or more patients in a placebo-controlled trial from those registration studies. And I always urge everyone to familiarize themselves with all the important safety information with APOCAN. The next slide, I think, is probably the most germane in terms of day-to-day clinical care of Parkinson patients who are either considering going on or are on APOCAN therapy, because it summarizes from a large open-label safety study that was conducted for over 1 year, the findings in over 500 patients. And it notes not only the frequency of when they complained of a side effect, but just as importantly, what % of patients actually discontinued APOCAN in the clinical trials due to that given side effect. So it points out that nausea is quite common, as is vomiting with APOCAN, especially when it's first started, but less than 5% of clinical trial participants actually discontinued APOCAN due to nausea or vomiting. Dizziness and even a tendency to fall can occur. Dizziness we attribute likely to the low blood pressure that APOCAN can cause, and we'll talk about those side effects of special interest in just a moment. The other side effects listed on this slide are all very commonly encountered with all dopaminergic drug therapies, meaning drugs in the same class as APOCAN, And in fact, Parkinson's disease itself can cause some of these problems, including problems like falling or difficulties with sleep disorders such as somnolence. Let's talk about a couple of side effects that we call special interest adverse events, because that's what we monitor for when we first initiate APOKYN therapy. We know in the U.S. clinical trials that orthostatic hypotension, and or syncope occurred in approximately 11% of subjects, but it was only classified as serious in less than 1%, and it led to discontinuation in only 2% of subjects. So it certainly can occur, but it's rarely of great concern, and it always goes away within 30 to 60 minutes and rarely leads to discontinuation of therapy. Nausea and vomiting can also occur just because of the nature of a dopaminergic drug like APOKYN. So we always recommend that an antiemetic, Tygan, be started 3 days prior to the first injection and continued for an average of several weeks or 2 months' time. It's really up to the prescriber's discretion. We know from the clinical trials that nausea can occur in upwards of 30% of patients, particularly when they first start APOKYN therapy. But as I mentioned earlier, the side effects of nausea and vomiting together led to discontinuation in less than 5% of patients in the long-term clinical trials. I'm going to move then off of safety of APOKYN and on to identifying the APOKYN patient. As I talked about earlier, a potentially good candidate for APOKYN is someone who continues to have a response to levodopa, but it's no longer a dependable response, so that they're having these fluctuations or roller coaster ride as they take their levodopa pills or capsules, and they have off episodes that interfere with their mobility. It's particularly helpful if the patient or their care partner can identify treatment goals, meaning activities or things that they can do when their levodopa is working, when they're in the on state. That could be a person who's working still, retired but active. It even could be a more sedentary patient, but who is still able to assist in their activities of daily living as long as they're in the levodopa on state, because that way the patient and their care partner can understand when to use APOKYN when they're in an off period, and they can judge whether they're getting a satisfactory response if they're getting that full levodopa-like on when they take their APOKYN injection. So it's important that either the patient have fairly good cognitive state or has an able care partner to assist in identifying these on and off episodes. Patients who are less than ideal are those with very significant cognitive impairment or perhaps other severe neuropsychiatric problems with their Parkinson's disease. Some Parkinson patients have relatively severe dementia or hallucinations, and that can be very problematic when taking an injectable like APOKYN. Patients who already have very severe dyskinesia, those are those involuntary wiggly movements that can coincide with their dosing of levodopa. APOKYN can make severe dyskinesias worse, so generally the prescribing physician will want to reduce some of their other Parkinson medicines before they begin to take APOKYN. And finally, if a patient has other comorbidities that are complicating or superseding their Parkinson's care, say they have significant heart disease or cancer or severe chronic obstructive lung disease, that now is really the emphasis of their day-to-day health care and not the Parkinson off episodes, then they're usually not a good candidate for APOKYN therapy. It's usually not well tolerated, and it's difficult to tell if APOKYN is contributing to their decline from these other medical conditions or is helping them. I'm going to start transitioning then to the patient support programs, and that includes, of course, our Circle of Care Nurse Educator program and initiations. We know that it's very important to find the optimal dose within those first days to weeks of patient treatment with Apokyn, because otherwise, because it's a as-needed injectable, patients will stop Apokyn therapy if they're not getting a satisfactory response from their injections. An optimal dose should give a full levodopa-like on response within 10 to 20 minutes, and usually will last for 60 to 90 minutes. We initiate and titrate Apokyn by having the patient in an off state, meaning we ask the patient withhold a dose of levodopa so that it forces their prominent Parkinson's symptoms to be very evident. That way we can check their response to Apokyn. The test dose is usually 0.2 milliliters. Sometimes 0.1 is given as a test dose in the case of patients who have impaired renal or hepatic function. The blood pressure is checked ideally both supine and standing before the first test dose and then at 20, 40, and 60 minutes after a dose. Really assessing the tolerability chiefly, but to a lesser extent the effectiveness, meaning do their Parkinson's symptoms now become controlled at that test dose of 0.2. If the patient has a good response and has no tolerability issues, they can be left then at that starting dose of 0.2 milliliters. In some instances, the prescriber or the circle of care nurse or patient would prefer to go on up to the next test dose of 0.4 milliliters to see if they can get a better response. This is usually not done at every initiation visit and can be postponed to a follow-up visit depending on the prescriber's wishes and the patient's response. If it's chosen to go up to the next test dose, you wait 2 hours from the time of the first test dose injection of 0.2 milliliters, and you can go up to 0.4 milliliters and then recheck the blood pressure again, supine and standing, for up to 60 minutes just to make sure that they tolerate that higher dose. Really, the guiding principle is to determine a dose that is tolerated and that gives that levodopa-like on response so that the patient can safely use it as needed for the treatment of their off episodes. After the initiation visit, the key again is to make sure the patient is having that continued good response. In the case of our circle of care nurses, they follow up with the patient with a phone call within a day or two after they're initiated on therapy, and then often offer to go back into the home at approximately 1 week after the start of therapy to re-educate or reassess the patient at that time. If the patient is unsure that Apokyn is working, our circle of care nurse or the clinician will reiterate that Apokyn should work like levodopa in a syringe, and to make sure that they understand how it is supposed to affect their Parkinson's symptoms, and are they technically administering a dose correctly? Have they learned to use the autoinjector correctly? And if not, the circle of care nurse will relay that back to the clinician. I think at this point, Cindy, I will turn it over to you.
Okay, thanks, Jean. Arlene, were you able to open the emails that I
No,
sent
but
again?
I'm following it verbally as much as I can, and I do understand everything.
Yeah. So if you can't see the documents, I don't think it's going to be worth. I can't verbally walk you through the flow and have it make sense. So what Lisa and I were going to cover is really Jean's done through the clinical training. Is how you will receive referrals. We would go over the portion of the home initiation form that you complete, meaning the home health nurse versus our nurse educator, And then I want to go over a document that we provide to all the home health agencies that sort of outline the expectations for the visit in terms of, what you can expect. But you really need to be able to see those, I think, for it to make sense.
All right, so what do you suggest, since I can't get it open?
Why don't we, Lisa and I have a little more flexibility than Dr. Hubble, so why don't we see if I don't know if you are going to be in another office or have access to a different personal computer tomorrow or the next day. I have flexibility both of those days, whereas Friday.
I'll be in two offices, one tomorrow, one Thursday, and I will have access Thursday all afternoon.
Okay. So Thursday, I have an opening between 10 a.m. and 11 a.m. Eastern. Lisa, let me pull up Lisa's calendar.
I'm
in the morning,
open today.
I'm going to be doing skills testing in the morning. I won't be able to do it in the morning, but I'm free in the afternoon.
Okay. I'm booked all afternoon, but Lisa, do you want to try to do something Thursday afternoon? I mean, you know this as well as I do, and that way you can just kind of walk her through that. Most of the work
I'm going to stop the recording.
Yeah.
I just wanted to let you know I'm going to stop the recording, but I want to wrap up the recording by pointing out, because others may be listening to this in the future, that we'll record a separate section on the logistical piece of initiation and the role of the home health nurse.